Dr. Ramos, I'll let you introduce yourself to the rest of the squad.
Cool. Ready to start?
Go ahead. Yep, whenever you're ready.
All right. So forgive me, we're going to be kind of informal today. But I didn't do too much preparation, but I know what I'm going to sort of talk about. And so the more you guys kind of help provide questions and stuff like that to guide the conversation as far as like what you'd like to know more of, I can riff. But it'd be better if you guys help me riff, and help me go off on that. But my name is Dr. Ben Ramos. I went to Western States. I graduated in December 2015. I was the national, international kind of director, coordinator. I mean, I kind of wore every hat in R2P for the majority of the time when I was in school. In addition to, I was the sports council committee national president for a while. I mean, I wore a shit ton of hats. Like, I just tried to do as much as I could and got involved as much as I could in everything while I was in school. Business club, SACA, went to NCLC every year. So just from a background perspective, when I was in school, I was that guy. So I love doing these kind of conversations and stuff like that, and I know how important it is. And with all of that being said, you're going to get a lot of, I don't really have much of a filter. So I'm happy to do these things because I know that that's what I wanted when I was in school and stuff like that too. So, so I think that'll be helpful in that regard. I'm an open book, and stuff I say today, I might be wrong on, and I might change my opinion on next week. So be prepared for that. You know what I mean? Like, nothing's static in my opinion and how we talk about this kind of stuff. Like you guys, I'm only interested in results, and I'm only interested in getting better and navigating life that kind of that way in practice and stuff like that. But I got to practice here in San Diego. Got right out of school. I was too stubborn to work for anybody, and I thought too highly of myself. So I went ahead and started to practice right away out of school. Trying to reinvent the wheel and stuff like that, go hardcore R2P stuff. I've always been in a performance center the whole time. I'm still in one now. And yeah, I'm just getting after it down here in San Diego, doing the whole chiropractic thing and trying to help people get better and get better myself. So I think the case that I'm going to be talking about today is going to be super relevant to all you guys, especially because the fact that you're on this call or whoever in the future is listening to this discussion wants to put more effort into helping their patients. Not to say that other people don't, but the fact that you arrived here to this situation and this scenario says a lot about who you are and what you're trying to accomplish and the amount of care. You want to be better. You don't want to fucking, you don't want status quo. You're trying to kick some ass, right? And so that's why we're here, and that's why we're having this discussion. And so that being said, the case I think that we're going to discuss today, I think is relevant to that because it's one of these scenarios that you're going to face and you're going to have to navigate in being motivated, right? And being motivated and trying to help people and stuff like that. I think this will shed some light on some speed bumps along the way where we can get on our own way, and where the way we interact with patients and the way and other people interact with patients, even though we all have the best intentions, can get in the way of the patient getting better, and how we can simplify things and think our way through things more effectively and for the benefit of the patient. So yeah, that's kind of what I've got today. I'm going to keep going because the first part of this is going to be kind of long. And what I'm going to read to you guys is the intake. So my intake paperwork's pretty long because I want to get a full story from people, right? I want to get as comprehensive as an understanding of what somebody's going through before they come in, because I mean, taking a good and detailed history, as some of you guys that have been in the clinic know, it can take forever, And so if you can get as much of that, pull as much as that stuff out of people through the intake paper before they come in, so you can ask more pointed questions when they do arrive, that's a good thing. But this first part's going to be kind of long, and forgive me as I go through this, but I think it's super relevant to the case, and you're all going to experience something like this. So I'm just going to get right into it, okay? So this guy was referred to me by very, very reputable strength coach, and was working with a very reputable strength coach, and that strength coach asked this person who to send to in San Diego, asked one of my mentors, a doc that all of you go, I'm not going to name any names here, but a doc that all of you guys know. I call him, like, just, and was referred to me down here in San Diego. Now, keep in mind, when that happens, you guys are going to have a big network at a school. You're going to have a lot of people that know you and trust you because of the network you've created. When you get referrals from that community, expect them to be more complicated. It's just a fact of the matter. But anyways, so moving forward into that, keep that in mind as we navigate this. I'm going to read you, in this part of my intake paperwork, it says, briefly describe the main reasons you're seeking our help. This is going to be long. Bear with me. Approximately 4 years ago, I started feeling pain on the lateral side of my left knee after cooling down from runs. I got worse and worse until it was very painful. I went to insert name brand practitioner here that you've all heard of and probably follow already. I stopped doing lower body stuff so I can repattern hip mechanics. One day I did a mild push press and my left knee twisted. Whatever was wrong was made 5 times worse. Had an MRI. Both meniscus torn. They didn't do surgery, just rehab. 7 months later, it was still very painful, but about a year I was limping a lot and still doing workouts. I noticed my body had created major compensations, but I was too stupid to really notice it. I ended up having meniscectomies on both knees. The knee pain went away that day. I was excited, and when I started rehab, my entire left side basically shut down, and my right side was working 10 times harder to compensate. For example, 2 weeks post-surgery, I tried to sit up and my left abs were soft as marshmallows and my right abs were screaming. Thus began several years of tension headaches from my right side pulling down on my head. At points, I could feel the muscles in my face pulling towards my right side. I was also twisted to the right about 20 degrees at my perceived neutral. And when I walked, my left foot was extremely supinated to the point of walking on the outside of my foot. You guys see where I'm getting at here? Like, this is, I'm a sixth of the way through this piece, okay? So I'm gonna keep going, but you guys see where I'm getting here? Okay, so we're gonna keep navigating this. So I've been to a bunch of PTs and voodoo healers over the years, and everyone has given me a piece of the puzzle. Fast forward until now my symptoms are definitely a lot better. However, every time I attempt to work out, my hips, ankle, spine, shoulder feel like they will snap and I will develop injuries quickly. And I can't produce the force because my nervous system is so toned down. Here's my current list of symptoms. My left foot still wants to pronate, which causes a lot of pain in the ankle peroneals. The left foot just won't lay right on the ground. Any modality that helps is immediately noticeable with how well my left foot spreads. I can't sit into my left hip. The glute does not fire properly. The best thing I can come up with is that my left side feels like I'm always prepared to step on hot coals with just my left foot. The pulling up garden sensation. One of my PTs told me that my left hip does not want to laterally translate. My right QL, oblique, and lat are extremely tight, causing discomfort. Stretching those areas to make things does make things better, but only temporarily. The right glute seemingly fires much better than the left, but it actually feels weird when firing, and I get pain in my upper hamstring when I do things like single leg deadlifts. I also twist to the right when I do pistol squats on my right leg. My left rib cage is flared up and my right rib cage is stuck down. When I force my left rib cage down, a lot of symptoms disappear. But then when that happens, I get these weird tightness in my left oblique hip. All right, so I'm going to kind of move on a little bit. This continues for the next, like forever, okay? And then he goes on to talk about all the different practitioners that he's seen. I'm going to go ahead and say that a lot of these practitioners that he's seen, we've all heard of, okay? They've, and I'm not trying to knock on these guys. I'm just pointing out that, you know, this person has seen a lot of what I like to call name brand practitioners. And that's not a knock. It's just the fact that these guys are good at doing social media and stuff like that, right? I'm going to tie that into what I'm going to get to later. But you guys see where I'm getting with here? Anything come to mind as I read this?
This person is super hyper aware of their body.
Mm-hmm. Yeah, they think probably, right?
Yeah.
Very hyper vigilant, and I'd be curious. I mean, I know you keep saying name brand docs on social media, but like, who's giving them this narrative, and like, why are they buying in so much to it? Like, it's definitely a cognitive aspect to it.
100%, right? And as I go forward with that, when I keep saying name brand, that's just what I call it. But I'm not trying to knock them. we're all doing our best to inform people the best we can. And, you know, like they say, communication is not what we say, it's what's heard, right? And I'm sure people have left my office at some, I know for a fact people have left my office maybe with misconceptions about what I was trying to get through. So when I say that, I don't mean that they did a bad job, or I don't mean that they intentionally did anything like that. It's just a fact of the matter. Okay, these are just facts. And these people that I talk about, name brand practitioners, I know they help a lot of people. I just say that to let you know that even the people that a lot of us historically, especially when you're trying to learn, put on a pedestal, look and follow and watch and look up to, are they make the same mistakes that we're all going to make. Okay. And the other piece of the puzzle that I want to point out is that you guys are going to find, because of who you are and what you guys do, you guys are going to encounter these people more than other people are. You know, they're going to come looking to you because you put the effort in, because people referred to you because you've got this more extensive knowledge or have thought more about it and have, you know, some of these credentials. This is going to come across your, this is going to come to your practice more often than you would think. This case is not unusual for me. Okay. So just keep that in mind. So we're going to, I'm going to keep going just a little bit more. A somewhat new phenomena: when I stand more than 5 to 10 minutes, I feel a weird tightness in my front of my left hip. My quad starts to go numb, and eventually my entire leg goes numb. Sitting down makes it go away. It was really bad hiking recently for several days. My left forearm also feels stingy. The extensor carpi area feels like it's tearing when I grip. When I wake up in the morning, my left ankle hurts to walk until I warm up a bit and always hurts. I've tried this therapy, that therapy, that therapy. I'm not going to name them because I don't want to dog them, but they're all things you've heard about. They're probably courses you've considered taking. There's another one here. Blank therapy has been the most helpful, and a system that that backed up what I found on my own. I realized early on that if I created a big belly or torso and breathe correctly, I unwind and feel a lot better. But as soon as I breathe out, I deflate and twist back into decrepitness. The outward bracing has made a huge impact on my right side, and it's always contracted and tight. However, I'm at best when I'm able to breathe properly, but I can't do it all the time throughout the day, and I can only do it correctly when I'm laying down. I realized that, okay, we're going to move on from that. And so he goes on to talk about all the different stuff that he's tried in an attempt to help this. The guy's tried everything, and he's tried every name brand technique or, you know, type of modality that you can think of that we all like, that helps a lot of people, right? And I mean, and what he's come back to is breathing, right? The guy, and I'm not going to go into it much more, but the guy is just obsessive with the idea of belly breathing, and that his ability to use and control his diaphragm is his problem, you know? And he's like, but I can't do it when I walk, and when I walk and I lose the pressure and this, that stuff, you know what I mean? He owns one of those belly breathing belts, you know, like which I want you all to take as a red flag if somebody comes in your office and has one of those. Or excuse me, not a red flag, a yellow flag. All right, keep in mind that person's put a lot of thought into this, or somebody else has put a lot of thought into them with regards to what's good and what not for them. So anyways, that's the first part. I know that was long, but I wanted to set the stage, and I think it was you. That felt long and dragged out, right? I did that on purpose. It was long and dragged out. I had to read that before the person came in. The history, when we came into the office and I said, okay, explain to me a little bit. I wanted him to speak his piece. You have to let people speak their piece when you come on there. It was worse. I scheduled this guy for an hour and a half because I knew I was going to need it, even though it was, you know, like, but anyways, that's where we're at. And you guys are right on where, you know, like, this guy's attuned to his body. This guy's seen to a bunch of people. But the fact of the matter is that he didn't come up with this on his own. You know, and he's been to a lot of people. And what can often happen is when somebody comes to us for help, in order to justify what we're trying to provide them from a solution standpoint, we can create more problems. Okay. Like we can create ideas of why we're doing it and make these hypotheses of why we're doing it. But in the process, create more problems and identify problems. Okay. And label them and give that to that person. The person comes to you with X problem. I'm going to implore on you to not give them more. Okay. Maybe lateralize and like identify what's more specific going on with them. That is the problem, but not give them more. Okay. And I'm going to explain that more as we come forward here. And the reason I'm bringing this, because I've done this and I've been through this with people. I taught people how to do that through things and presentations and stuff like that. And I feel like it's my obligation from doing that and being a part of that to explain this to you now as I evolve as a practitioner. Okay. And I'm not going to just tell you problems. I'm going to tell you solutions. All right. So I'm going to go right, because this is supposed to be a case study. I'm going to go right into the physical exam stuff. We're not going to get too detailed there, but I mean, every single one of you guys is learning how to be a clinician. Your physical exam is enough. Okay. Follow your physical exam you're being taught in school. I don't need to go over a bunch of crazy stuff because you guys are all going to be competent clinicians. The stuff they teach you in school, even though you feel like it's not going to be, is all the stuff that is quality exam procedures that you need to identify what's going on with the people that you're working with. Believe it or not. Okay. I know it doesn't feel like that while you're in school. You feel like, oh man, like there's so much more to it. No, you're a clinician. You're going to be a doctor. The clinical stuff you're learning is enough. But anyways, my exam was pretty straightforward. You know, when we went through the regular at UWS, we do a LoQSMAT for chief complaint. All of those things relevant. We went through all that. You know, I just did a basic kind of like analysis of the way the person's like general body postures are, if there's any antalgia. I kind of watched his gait as he's coming in. I did a bunch of orthopedic tests. In his case, the seated compression test with flexion and seated compression test with extension reproduced his chief complaint. The chief complaint of hip numbness and pain and dysfunction. But he also had back pain, which he didn't focus on because he was worried about the numbness. I did some neurodynamic tests. He had a positive slump test on the left side. He had a positive femoral nerve tension test as well on the left side that reproduced his chief complaint in his left hip. I did, like, you know, basic CNS exams, time, space, person, all that kind of stuff. Did a range of motion. He lacked extension. Extension active range of motion reproduced his symptoms in his anterior side of his left hip and the numbness stuff. I'll get into that a little bit more. I just, you know, extension hurt. I had him sit down and I had him sit in a flex position with his legs bent. That took away his symptoms. So I think it's fair to say I didn't do like a traditional McKenzie style to the book exam like that, but you know, pain with extension feels better with flexion. I'm going to say flexion is what we would consider a directional preference. We cool with that? Yeah. Okay. Tissue tone changes, you know, thoracolumbar paraspinals, QL, whatever, low back muscles, all the shit in that area, tight, tender, upset. I mean, you have to write on notes specific muscles and stuff like that. But I mean, I don't know what the fuck I'm touching. Like I'm you know, paraspinals, QL, that's about as specific as I know I can get. You know what I mean? Yeah, butt muscles tight, you know, like that's, you know. So his chief complaint was that he had numbness and all this kind of stuff going on there. Oh, I did a hip exam. Hip exam was normal. You know, no orthos, no nothing crazy there. He's got good hip mobility, all that kind of stuff. I did all the other regular exam procedures, muscle tests and all that. That was all unremarkable. DTRs, all that stuff. All the basic exam procedures that you're taught to do that you should be doing every single exam, I did. I'm just giving you the pertinent findings. So coming back to the pertinent findings of the exam, I can talk about all the kind of stuff that went on, but the most important piece was that he had what I consider extension related back pain, and he had radicular symptoms as a result of that. We cool with that? That makes sense? Yeah? Okay. Throughout this process, I'm having to like get to I'm trying to be focused on him, because what I'm trying to do is identify his problem. Okay. And when I say identify his problem, he comes in thinking that he's got 50 different problems or as to what's happening with him. The fucking guy has ridiculous symptoms. That's his problem. And every time he tries to get active, he has ridiculous symptoms. That's his problem. That's what he's scared of. But he's attached onto this 50 new problems. But his fucking problem is the ridiculous symptoms that he's dealing with. We cool with that, right? And I asked him, so when this happens, I asked him, I was like, okay. And I'm not a genius. I just do this because fuck, I would want somebody to talk to me like this, you know. This is just and so I said, like, hey, you know, like, if you felt all these compensations that you're feeling, if you felt disconnected, if you felt, you know, things not firing right, things not working right over here. And this was a veteran too, right? And a guy that it wants to kick a bunch of ass too, just like you guys do, you know. I was like, if you felt all this stuff, all these compensations, all this stuff, you felt like you couldn't breathe right, all that stuff, but you out of pain, you could do all the things that you want to do sustainably, and you felt like you could do it in a safe manner, and you could improve at the rate at whatever it is that you want to do, would you care about all those things? Right? And I think that's an answer that we don't provide. That's a question that we don't ask people enough. And the fact, and how do you think he answered? He's like, dude, yeah, that sounds great. You know, I would be cool. But when I asked him that, he looked at me like I was saying something unrealistic. But the fact of the matter is, all those things that he's feeling like that, they may or may not be related, right? They may have been something that he was pinned to. Could they be related? Yeah, maybe he feels something wonky here. I'm not trying to discount that, and I let him know that. I'm not trying to shatter his idea and self-image and stuff like that in the visit, but I was just laying the groundwork there. Frankly, when this guy came in, I was ready to be the person that he needed to be and shatter some of these thoughts, and understanding that he might not come back to me again. But I knew he needed to hear it from somebody, and I was prepared to be that guy to lose that patient because of this. Dude, I'm in the losing battle. He's been to 10 guys that are, you know, that are smarter than me, more popular than me, more famous, whatever. I'm not famous at all, but like, you know what I mean? Like, I don't even post on social media anymore, like, for my practice, but like, you know, you see where I'm getting at here? And so I'm fighting a losing battle already. He's coming into me and I'm nobody, but somebody he trusts referred him to me. Okay. But when I asked him that question, and when I posed that question, I'm just trying to set the groundwork for him. Like, hey man, like, this is the problem you have, right? Yes. If we fixed that and you can do all those things that we're talking about, but you still felt all this, would you be cool with that? Like, hell yeah, I'd be cool with that. But that's not, you know, he's thinking it's not realistic. But the fact of the matter is, those things are two different fucking things, right? And those have been put as obstacles in his way to recovering and feeling better, but they don't need to be, you know? So all that stuff that we talked about in his history and all the stuff he's still feeling it. The guy's problem is extension-related back pain with ridiculous symptoms, okay? There was no special exam that you can learn from taking a course right? Or you could learn from taking a course, but there's no special exam that you're not learning in school right now that you're not going to be tested on during your Part 4 boards that's going to lead you to this conclusion. All right? That's something else I want to hammer home. It's just a fact of the matter, dude. You're going to do active range of motion. The dude's going to light up. He's going to have ridiculous symptoms when he extends backwards. The best functional exam I perform is not SFMA. It's not FMS. It's not DNS. I took 50 continuing education courses before I finished school. Took them all. You know, I got SFG certified before I finished school. I've been through all of them. I took 13 DNS courses. I did an internship for 6 months with a DNS instructor. Philip Snell was my first preceptorship. Like, I'm just saying, like, I've got all this. The most important functional exam I do is active range of motion and sustained postures. Okay. And what I'm trying to hammer home there is that simple is better. And this guy needs simplicity, right? He needs simple answers. He needs simple and flexible solutions, and he needs realistic expectations. Okay. And so what did I give this guy on the first visit? So once we get through the exam and the history and all that stuff, we're pushing, and this guy was at the very end of the day, you know, so we're pushing like well into our hour and a half window of time, and I've got a life. I want to go home and eat, you know, like I was busy all day, didn't eat shit all day, but whatever. Like when you get in the zone, you're flowing shit. So but I had to keep it simple. I couldn't give him too much. You also don't want to give people too much in the beginning. His homework was to sit down in a slumped flex position with his knees bent. Because when we did that for a prolonged period of time here, I sat him down in the chair and I just had him sit just in a slumped, shitty position that he was like, I can't believe you're having me do this, because I try to sit up all the time. I'm perfect, da 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 da. And his fucking symptoms went down. And he felt better. And that's not magic, and I didn't learn that technique in anywhere like that. You guys know what biomechanics of the foramen is, right? You guys know what happens when you extend on a pissed off nerve, right? You obviously know what happens if you flex on a pissed off quote unquote disc, or somebody has flexion intolerant low back pain, right? So we have to make sure that we're not doing that. So this is an odd case, because this goes against, we're not doing prone press ups in this position. We're not doing extension related discogenic type stuff in this position. This is a weird case, you know? But it's going to happen, and it's for real. And I'm just following what happened. Oh, fuck, like ridiculous symptoms when you extend. Feels better when you bend forward a little bit. Let's do a little bit more what feels good, right? It has nothing to do with his breathing, dude. You know what I mean? How can it relate to it? It can relate to it if he's in a prolonged extended position all the time, you know what I mean? And if focusing on different types of breathing biomechanically takes him out of that super extended position and lets him open up a little bit more. But that's unrelated to breathing. That still has to do with not being extended, right? So anyways, this case is ongoing. I'm still fighting the battle with this guy right now, but I just wanted to go over like the initial part of it. I like the communication aspect of running a practice. I want my patients, I was like, if you have thoughts, ideas, feelings about what's going on between visits, I want you to send me an email. I want you to get it off your head, dump it in my inbox, whatever, so I can read it before you come in. Frankly, I'd rather read it before they come in than have them come in and dump it on me, like right there in the appointment. At least I'm prepared for it to navigate that. But what I read to you as far as on the intake thing, I get that for every appointment almost, about new stuff. Okay, still, we're making progress, but new stuff. But I've gained his trust because I've been able to make a positive change on his symptoms, you know? And that's the biggest piece of it. And he also knows I'm not bullshitting him. But that has to do with interpersonal communication and all that stuff. And we come from a similar community in the military. Again, it's ongoing. It's not that I fixed it and things are better and all this stuff, and I shattered his negative thought processes and we're on it. No, he's still got those things. Those still belong there. But I've got to come back and reel him in every single time, you know, and go over more. But we're still working on it, but it's going to take time. And I set realistic expectations for him. Like, how long? This has been going on for 4 years. This has been bothering you for 4 years. I was like, how quickly do you realistically think that we can fix this? He's like, shit, man, I've been trying to fix this for 4 years. I'm like, okay, so if we start moving in the positive direction, how long do you think? And I'm just setting the stage because you're not going to be able to fix everyone with 1 or 2 parlor tricks. You know, it's not going to happen. This guy, I don't know how long he's going to take to get better. It may take a year, dude. You know, I think we can get him out of the ridiculous. Oh, we've already got him out of the ridiculous symptoms because he just sat in a flex position for a week. Boom, they were gone. You know, imagine that. Like you stop stepping on a pissed off nerve and it becomes less upset, you know? But it's going to be ongoing. I set the expectations like, dude, this is going to take a lot of time. What that does is that buys me time to go through this entire process with him and guide him through it, right? Because it's going to take a lot of guidance. He's going to need to get reeled in. But that's kind of where we're at with this case right now. I'm still working with him as far as when you have and this is not the crux of the case. The crux of the case I want you guys already know about, and I've already kind of hammered a bunch. But from his actual problem standpoint, he's got extension related radicular symptoms. What do? He's always in extension. He's got hyperactive muscles on the backside. We activate, work on, get him to focus on using the muscles on the front side in a productive manner, whatever. Call it core work, call it whatever it is. I frankly, the other day, I had him in here. I put him in a flexed position, and then we just did core work from a statically flexed position. And he fucking felt better. Why? Because when you do bicep curls, afterwards, your elbows are kind of bent because you've got a pump, right? Everybody's experienced that, okay? You do a bunch of like lower abdominal work, you're going to be in a little bit less of an extended position because you've got that lower ab pump. How many reps are you going to do? I want you to do it till infinity, or you need a break, whichever comes first, right? And so, because you want to just get it working as hard as possible. But that's kind of my approach for extension-related back pain. There's more on that stuff with Seb Gonzalez's. I think I did a talk on that and stuff like that with Seb Gonzalez before. But that's simple. That's simple stuff that you're all going to find out and that you all probably already know right now. But what I wanted to hammer home is that this is the situation that he's found himself in. I've put people in that position before. You're going to put people in that position in the future. Hopefully you'll be better about it, and I can explain to you like this kind of stuff so you don't do it, but it's going to happen, and it is what it is. But by keeping things simple, by focusing on the real problem, you know what I mean? Peeling away all the layers of all the shit that we think's happening and producing new problems and sticking with the real problem, because what we need to do with people is we need to fix the problem they came in, you know, to us for. Not provide new problems, not provide new kind of shit. And it's easy to do, especially for us that care and that want to kick ass, because we want to know things that other people don't know. Right? But that's the case. What do you guys bring to mind, and what other kind of stuff do you want to hear about this, and what kind of, you know?
Go ahead, Tosh.
With that kind of patient, how frequent, like how do you determine the frequency of seeing that person?
For like a chronic patient like that, for the initial phase of stuff like that, I tend to see those people. We know it's going to take a long time. We know they're not in acute stage. I tend to see him about once a week. So I've seen him once a week for 6 visits so far. And granted, the first visit was super long. The first visit was like an hour and a half, whatever like that. Dude, the first 45 minutes was us talking. Like I just knew it was going to happen, but I knew he needed that, you know? And and I made the time for it, but the second visit was about 30 minutes. The follow-up visit after that was about 30 minutes. Now I only see him for 15 minutes every week. And the reason being is because granted, I came out of school, like I'm seeing everybody for an hour. Like, you know what I mean? People deserve time. We're going to be doing like mobility. We're going to do like strength training. Like we're going to handle this shit. We're going to hammer this stuff in the office. But the fact of the matter is that's less effective in the long run. It really is. And I've learned that over time that's less effective. And that if we can keep things simple, and the biggest thing, the reason I say this is the biggest thing that you're going to realize that, you know, it's like, oh man, 3 to 4 visits, and they're out the door. Like, you know, like that works to solve now problems. That's not as effective as solving the problem. Okay. I learned, don't get me wrong, I'm one of those guys. I just take pride on getting people out of here faster. And you should too, because if you can get somebody better faster on their own and out of there, that's great. But not everybody's like that. And a lot of these people need your prolonged help. And getting somebody out of this situation now and then having it again in 3 to 4 months is not solving the fucking problem. You know? That's my personal opinion. I have people that, and you'll ask any doc, that's being honest with you, that's dealing with people that have really chronic conditions, stuff like that. There's some people you're going to see once a week for a long fucking time. But you're going to move that gauge every time. That doesn't mean they're relying on you. That means that you're working on something. That means it takes consistency. That means inputs, you know. The people that I work with on that, they get better because they see me and they're revisiting that. They're kind of recollecting that. We're reeling things in. We're changing the plan, modifying it, moving forward in a positive direction every time. Some people I'll fucking see one time, you know? But for this type of case, this kind of situation, I navigate it as it goes. But what I usually do is I ask them, I was like, give me once a week for the first 4 weeks. Let's see what happens. And if we're able to make a positive change in those times and you think we're on the right track, we'll keep going. If you feel like, and I'll be like, if I haven't been able to help you in that time, I will try to send you someplace that will, but I'm not going to waste your time and I don't want to waste your money either. Why do I move from that long period of time? The half an hour, I knew we weren't done talking. The next visit, half an hour, I knew we weren't done talking. The next visit, I'm speeding up the conversation because he needs to be cut off, not cut off, but we need to be like, hey, like we're past that, dude. You know better than this. We're past that. We're moving on. Like, let's talk about what's important. Let's talk about the real shit. And that's how it goes. And so what does that do? It's consistency over time. You know, not everybody can pay to see you for an hour every single week, you know, and this guy's seeing me out of pocket. Not everybody can pay to see you every week, but you can, if you get better at communication, you get better at implementing your whatever type of therapy or whatever like that. You can get a lot done in 15 minutes, but if I can keep him coming in, if I can get him in here, let's say, for instance, just use basic timelines, 8 times for 15 minutes, that's 2 hours worth of total time. If I saw him for 2 different 1-hour sessions, we would accomplish significantly less. Does that make sense? Throwing a lot of stuff out there. Not everybody's like that. Other people need different things, but I notice with these type of cases, that's the real truth. You know, and this is coming from me who started my practice that everybody's getting an hour and I'm just doing an hour for every person. So I know that was a lot. It all depends, but I know that was a lot to answer the one question, what's the frequency? Fuck, I don't know. If chronic person like that, give me 4 times once a week. It's chronic. We're probably not going to get a lot done in twice a week at that point in time. If somebody is acute, I have no problem seeing them twice a week for the first 4 weeks.
Cool. Doc, do you think, so you mentioned that he was a veteran. Do you think that changed the way that you directed the conversation, or like you started that conversation with him? Because like you mentioned how you were like, just how you had to kind of, you weren't trying to change his beliefs, like he's going to keep those, but you had to like let him know like, hey, this is the actual problem. Like, do you feel like that conversation changes depending on like who the person is?
It has to, 100%.
Yeah. Like, just because he's a veteran, you felt like you were able to be like a little more upfront with him and just kind of tell him like what was going on.
Yeah. And I think that was an advantage that I had in this situation too, for sure. Because not only is he a vet, but like we were from like literally the exact identical community within the military, and so like we had that connection. But to what you're saying, man, like. And I learned this a lot from Dr. Philip Snell, being inside the room with him and preceptoring with him, because he's magnificent in his communication and his ability to navigate his conversations with patients, right? Like when you're in the room with him, when you are in the room with him, he is a fucking good old boy 1 second. He is like hardcore technical, like, you know, whatever guy this next second. And then he is like really soft and gentle and whatever. Like his ability to put on what he needs to do with each person in each given situation, like legit, he's a legit clinician. Like he knows all kinds of amazing stuff. That's his actual power. That's his actual superpower. All the stuff that Dr. Philip Snell knows, you know, because he'll teach it to you and you'll have it. It'll make you super effective. But to me, and you guys know this communication stuff, if you can connect with somebody and get them to trust you and get them to work on with you, because you may not do the right thing the right time, but if you care, you're going to use that retest mindset and you're going to modify what you're doing in order to narrow it down and get to the right thing, right? But you can't get there unless you have that connection with somebody and that communication. And so to what you're asking, it's extremely important. This was easier for me because this was like me and him hanging out like me and him, I was able to be a lot more direct with him. And frankly, I see a lot of veterans because of that, and a lot of jiu-jitsu guys because of that. But I mean, I have housewives in here as well that we just talk about kids. We talk about like that kind of stuff. We talk, like you have to, dude, you have to relate to them, no matter how hard it is. But yeah, I talk about things that I don't want to talk about all the time because I have to, but it's the job. You know what I'm saying?
Customer service. I have a question. I really liked your thought on having them email you in between visits of like any like thoughts, ideas, feelings, or concerns, because then kind of puts you in a place to kind of rebound anything that they're feeling and like prepare for where they're going to be at in like a mental state. And if it's changed when you next see them, then you can at least bring that up, because that might be like a subconscious thing and like they feel fine that day, but it's like, oh, they kind of felt that way through. I also feel like that allows the patient to kind of write stuff down and get it off their chest with the emails. But how often do patients actually follow through on that? Like when you provide them the email, and is it just with chronic patients or even acute patients? And how often do they actually follow suit with that offer?
Not all the time. Maybe 10% of the people, if that. Maybe between 5 and 10. But I tell every single patient that line because I feel like they value it and they appreciate that open line communication. Most of them don't want to bother with talking to me about it on their off time either. But what I explain to them is I want, if they have, I've been there, dude. I've been there when I've gone to a doctor's office and then I have these questions that I want to ask and I leave, I get to the car and I'm kicking myself for not asking, And I tell them and I explain that to them. Most people have experienced that. And I say like, you might, that's a possibility. But what I want you to do is if you feel like you have something that's on your mind, even if it's on your phone, even if it's a couple bullet points, offload that off your mind and send it to my inbox. Like I give them that open invitation and most of them really appreciate it. Not everyone takes advantage of it. It sounds like, damn, you must have like a full inbox. Not the case at all. Not the case at all. Frankly, I wish some of them would do it more, because some of them come with all this shit, you know what I mean? Like, hey, welcome back, come back. And they comes getting off the waiting room chair looking like they just, looking like shit, like, and you're like, fuck, all right. Like this person had a bad deadlift session yesterday, but yeah, not that much, but I think it's good to have that open line of communication. And I mean, and I'm pretty busy, so it's not like it overwhelms me, but I think it's probably it's an important piece of the puzzle for me in the way I practice that I think helps a lot. And I know it's not for everyone, but it doesn't get in the way too much. I spend a lot more time on fucking soap notes than I do on that stuff. So, that's more of an issue. So.
Yeah, I like that. It's like a therapeutic alliance with you and the patients. And that's why I was curious how often they follow suit with actually reaching out.
Yeah. And I've been able to develop a barrier between myself as I've gotten busy and them. I want them to know that they can, like you said, it's getting off their chest. It's getting off their mind. It's taking action to get it away from them and disassociate and detach from it, knowing that they've taken an action to help whatever it is or whatever thought, you know what I mean? That's therapeutic for them. Yeah. I think it's super helpful, and I think it's really important to do that. At least for me, something I've done. But it doesn't overwhelm my practice at all. It would be maybe if I had a lot more people that were sending that kind of stuff, but yeah.
I'm just curious on your response time, or do you just address it the next time you see him, or do you address it in like 48 hours? How do you set the expectations?
Oh, so I set the expectations to talk about it at the next visit. I don't set the expectation that they're going to get a response from me, and I let them know. That way it's like, hey, I probably won't be able to respond. We'll talk about when you come in, but I don't tell them it so we can talk about it through email. I tell them it so they can offload it so I can be as best prepared as possible before you come in for your next visit. Like whatever. Like I made that sound really corny, but that's kind of how I frame it. I like, if you have anything that you can tell me, anything like that, I'm going to do my homework before you come in, and I want to be as best prepared as possible. That way we can have an awesome visit. We can get you moving in the right direction. when you come here next time. So, let that to me, but it's not, let's talk a bunch in between visits. So that expectation is set there. I do, however, tell people, if I think there's a potential for them to have some sort of an issue or anything like that between visits, I do tell people like, hey, if you feel like something's going wrong with the plan and we need to modify the plan, and you're having some trouble between now, this visit and the next visit, let me know, because sometimes we can modify the plan over the 5-minute phone call. And I do that for some people. Most people don't take advantage of that either because they don't need to. They don't want to waste my time. They don't want to spend more time on this either. Like they don't, they've got lives and stuff. But there's been plenty of times where, somebody, and this is what I like to tell people too, like however long we spend on an exam in here, that's not the real assessment. The real assessment is how their body responds to the plan that we've created between the end of their first session and the next time I see them. And they need to know that. And they didn't know it may potentially be a new moving target. So I lay that out for them. And if I sent them away with something that we tried to discover here, and that's the thought process we went on it, and we discovered later that, being in a sustained flexion posture, like we told this guy, aggravates symptoms or changes things or whatever like that, like, hey, let me know, because we'll change the plan. Even if it means hop on a phone, had a quick 5-minute phone call, I'd rather do that than deal with somebody coming in who's continued to do something that has not helped them, or even worse, made them worse. Matter of fact, I frame it if it pisses things off. I don't frame it if it doesn't help. Mostly, right? Because that's more what we're worried about changing on immediate, But yeah, so I also do that, and it honestly doesn't happen as often as you would expect either. But it happens, Like you'll have somebody that has dual things. You'll have somebody that comes in with acute lumbar disc, but they have a history of an extension intolerance problem, and so they will be. You'll give them like hanging on elbows or like an up dog kind of position for low back extension that help their acute lower back thing, but when they do that, they are hyperextending from the thoracolumbar junction and creating other problems. And so you may not be able to identify it within a session here, because after they do it a bunch on their own, they create problems, but you need to be able to modify as you move. So that's a potential there too. But no, to answer your question, I drift, see? So if you get me going in a direction, I'll riff good. But no, I don't. I tend to not have conversations via email. It's more for them to offload and for me to prepare for the coming next time.
Go ahead, Jay. Do you have a question?
Just because since you kind of brought it up, question like regards back to like the case. This guy was kind of flexion was like his preference, so you were kind of hammering away the flexion. At what point, like at least your thought process, like I'm sure like it's going to be dependent. You're going to retest each session to find out when they're ready for it. But like, what's your thought process? Like, when do you think is the good time to start reintroducing like some extension based stuff for him, or even just extension related movements like walking, something like that? Like, when do you feel it's right to kind of start to, I guess, poke that bear again and kind of build resiliency back into that?
Here's the funny thing is we make it seem, the thought is, and we make it seem, and we think about it in terms of like, we make that decision, right? Like we really don't make that decision, dude. More often than not, that's going to happen naturally without us, like he's going to have to walk, I mean, frankly, I'll go as far, dude walks in here in hyperextension every single day, or it was what we would view, what I mean, as hyperextension, whatever. It may just be his normal neutral posture. So like, but he walks in here, like, he walks in here kind of like this. You guys, you know what I'm saying? Like every single day. It just doesn't piss it off as much. And I'll even tell him, I'm like, he's like, so what do you think about like, so that's one of the big things. He's like, okay, so we're on to something. You know what I'm saying? Flexion feels better. You know what I mean? But like, I still find myself extended throughout the day. How am I going to fix this in the long term? I'm like, if you didn't have symptoms, but you were standing like that and you're extended, but you had no problem, would you care? Like, I'm like, dude, you're going to probably stand like that. Like we're probably not going to be able to avoid it. It's going to happen. So I think that's more of a natural progression that's going to happen whether we like it or not, And if I can go off on a little bit of a riff on that question, keep in mind that usually gets taken care of with good, sustainable, safe, and thoughtful training. You know, just basic training that a person does. Like, it doesn't have to be super specific. Like, you know, we'll give them a couple tools now. Like this is how I frame it for patients. Like the flexion stuff, for this guy. So it's your directional preference stuff, your tissue work, your whatever it is that addresses these symptoms for the problem they have now, your rehab exercises, your mobility stuff that you're giving for the person's problem when we're addressing the problem is their medicine, right? Good, sustainable, thoughtful, quality training that gets them working to their long-term goals is the healthy meal, right? And that's how I frame it for them. And it doesn't need to be any more complicated than that. You know, like I have my own thoughts on the training process and all that stuff. And I've gone down that rabbit hole really deep too. But frankly, just good, safe, sustainable training, general training, that's going to get that done. That's going to get that done. And if you need to change a piece of the puzzle, modify based on how he responds when he goes through that, that's like, you know, you're just making modifications to make it safe and make it sustainable and make it quality training. You're going to do that. That's going to be a natural progression of the training process. You don't really have to overthink that too much. And again, most of that stuff that you're talking about is going to happen naturally, but we're clinicians. Your strong point, the reason people are coming to you is for that medicine. You can give them advice and everything like that. And some of you guys are going to want to go out and do the training stuff and be more involved in that stuff. And that's cool. And that's helpful. You know what I'm saying? But people are coming to you for the medicine. And so your job, your primary job is clinicians. So most of the time, that's where you're going to be spending your time. We don't have to complicate their training. You know, if you know good trainers and stuff like that, you trust that you can send them to do good basic training. The trainer's also going to appreciate that more too. You know, so that makes sense.
Yeah, definitely. I know. Like, I think it kind of comes back to that point that you brought up. Like, simplicity is better than complexity. You know, like sometimes I think I will tend to overthink. Like, all right, I want to make sure I'm doing all like these exercises are a little bit more like, I guess, favored to flexion, so we don't piss things off. And it's like, like you said, like maybe just have him sit in that position is better off, and then let's find movements that he could train to get to his life goals without pissing things off, and run with that.
Yeah, make things happy, get stronger.
Yeah, I like that. Yeah. Put on a t-shirt.
Yeah, what's that? What's his? Greg Lehman has a good one that he already coined for, and it was like,
calm shit down, build shit up.
That's really it. That's really it, dude. You know? Yeah. There's more stuff that goes on in between, but that's yeah, totally. And past us, past what you guys are going to specialize in, right? Even if you guys come back from the strength and conditioning background and you guys are like badass strength coaches, stuff like that, and you can program your ass off, that's awesome. People are going to be coming to you because you're a fucking clinician, you know? And that's going to be your new bread and butter, you know? So you got to like change that hat, put that clinician hat on, and hammer that piece, because that's why they're coming to you, and that's going to be your new superpower. That's your legit superpower. You know, if you're a badass strength coach and sports performance coach, that's great for specific goals, but you're not going to be seeing people that are going to be coming in usually that are athletes with these outlandish, crazy, specific goals like you would be if you were working in a training room of a college. It's just not going to happen. You're going to work with a bunch. Most of us are going to be working with don't get me wrong, it does happen, and so you tailor it, but that ends up just being, you talk to any good strength coach, dude, that's just regular old good fucking training too, you know, even for those specific athletes, right? But yeah, that.
Awesome. Thank you.
I think I made my point.
Yeah, thank you. Appreciate it.
But the other piece is like that I think I can hammer home that I had trouble connecting with too. Because when I got out of school, you know, like I did the whole CSCS thing. I did my SFG thing. I spent a bunch of time in like, you know, perform better and that kind of stuff. And I really hammered into the strength conditioning stuff and all that stuff. And I had plans to like be really involved in that stuff and try to be this jack of all trades that seems so really cool and awesome and stuff like that. But like, I am so much more focused on just being an awesome clinician now. And it's been to the benefit of everybody that comes in here. And it's been to the benefit of the relationships I've developed with the other people who actually do that role really well. You know, I mean, I built my practice off getting referrals from strength coaches, personal trainers, and stuff like that. And I still have a lot of that going on now. And I still send people out for that kind of stuff too. Can I help people do that stuff? Yeah, I do it via advice, you know, like I don't like, I mean, fuck, I've been doing the same workout program for the last forever. You know, like if you change your workout program, it's more because you just get bored than it is because it's no longer effective for most of us, you know? So, but anyways, yeah, I got my own thoughts on that. I think I think a lot of personal trainers and myself included had trouble realizing that most of that is an entertainment industry than it is a fitness industry.
Awesome. Hey Doc, I think we might have I think you finished that. You ripped perfectly to 1 hour. So I don't know if Zoom's gonna kick us off, but I don't want to cut you off or anything like that. So if you want to, I don't know if we're allowed to slide in your emails at all, or if that's just for patients, but if you want to give a shout out to how to contact you or anything like that, if anybody has any questions, and then we can close this out.
Yeah, Dr. Ben at flowforcerehab.com. You guys can feel free to email me. I will tell you straight up, this is set the expectations, you know, like I'm still trying to build my practice and stuff like that the best I can. My focus has to rely on the practice. You guys will understand this soon. I will respond to you, and it's not that I don't care. I wish I had way more time to dedicate to this kind of stuff, because this is like, I'm super passionate about this. I'm super passionate about your guys' growth and helping you guys. But I may not get back to you right away, you know, but I will get back to you. But I totally want you guys to reach out to me if you guys have questions, and if you want to reach out to me. And in some cases, I do this quite often. Like, we can organize a quick phone call or something like that, and just have a talk and that kind of shit. I'm all about it as long as I can. You know what I mean? But yeah, please do. Yeah, Dr. Ben at flowforcerehab.com. Hit me up, and you know, and if you guys have any like challenges or something like that, you guys want me to challenge me and what I'm saying here, that'll change the way I think and shit like that, I'm all about it. But you know, like, just to hammer home, if I can hammer home the principles that have helped me help more people that I learned through the process, because you guys are learning how to make things more complex right now, right? I know you are, because I was there. You're learning how to make things more complex, which is good. You want to make things as simple as possible, and only as complex as they absolutely need to be. You want to focus on keeping things simple like that, so you can make people be able to be consistent, right? Because consistency matters more than any trick that you have. Keep the problem, and don't create new ones. Like, don't put any extra stuff on there. Like, don't lay it on there anymore. And think. Like, the last thing I can say, the most important skill that you're going to have in treating patients is not a technique. You guys are literally learning, like, from the most important thing you're learning in school. I know it sucks. It's fucking crazy. And it didn't feel like, but the most important thing you're learning is the physical exam that you perform in school. That basic clinical thorough exam is going to give you everything you need to know in order to solve the problems that are going to come to your office for the most part. Okay, to identify them. But think, right? Like, don't let anything fit into the box. Think, be logical, and be flexible. And you guys are going to be able to help so many people. That's what I got.